I've brought our four experts together to continue having this discussion, and now we are going to bring your questions to the experts. And Dr. Seppala, I'm going to direct the first question to you, and here it is. I am on medication-assisted treatment, and I have been turned away from 12-step meetings and told I'm not in recovery because I take medicine. I think the rift in the community is still a problem. Can you talk about this?
Yeah, unfortunately, it really still is a problem, and worse in some parts of the country. And we've had to face this for a lot of our patients, and we actually call it stigma management because we try and prepare them. Nonetheless, the stigma is about the use of the medications, and yet most people don't stay sober. And with opioids, the risk of overdose, especially after a period of abstinence, is tremendous. And we cannot allow, the 72,000 or more overdose deaths per year to continue. So we need to do everything we can to help people. And you can find meetings that are favorable to the use of medications. We do that within the communities. We have treatment programs, and I would suggest calling different treatment programs to ask about such meetings. Also, we've found that Alcoholics Anonymous meetings are more favorable to medication use than Narcotics Anonymous meetings, where their national group has kind of forbidden that to some degree, and biases exist. So it's really a matter of, finding other people in recovery, asking them about favorable meetings, talking to treatment centers, other addiction experts to find some place you can get to safe meetings where they're not going to give you a hard time about the use of your medication.
Dr. Welsh, another question from a viewer is, we have a clinic in our town that gives medication to people who are addicted to opioids. We don't see this as helping our town. How can this possibly be a good thing?
Well, stigma really is a significant barrier to receiving treatment and can be both internal, meaning the person experiences some degree of shame about their disease, or external, where they are shamed by others. We really wouldn't stigmatize a clinic starting in our community that manages diabetes. Similar to diabetes, addiction is also a chronic disease. Just like patients with diabetes take insulin to manage their condition, medication for opioid use disorder treats the symptoms of a substance use disorder, such as cravings and withdrawal. And when properly prescribed, these medications do not cause a high. Individuals stabilized on medication for opioid use disorder can achieve recovery because they're not experiencing other signs of an active substance use disorder, such as loss of control or giving up important activities because of drug use. Data also demonstrates that 90% of people with opioid use disorder who detox only and do not enter residential treatment will drop out of treatment and/or resume opioid use within 2 weeks. Providing treatment really helps communities.
Thank you, Dr. Welsh. We have a bunch of other questions, and any of you can answer as you wish. How do I safely get rid of opioids?
Well, I'll take that one, and I think that is a fantastic question because it really amplifies the importance of discussing safe storage and disposal. And so I would say if anyone has opioid medications that they are taking that as prescribed by their physician, they should make sure that they are properly stored away. They may even need to be locked away so that only the person who is prescribed the medication has access to the medication. And then we get to the important question of disposal. And I would say that the first thing I don't want folks to do is flush the meds down the toilets. I want everyone not to do that. And then there are other ways. You can dispose of the meds in kitty litter, maybe purchase kitty litter, put the meds in kitty litter, and then put them in the trash. This is an important conversation to have with your pharmacist and your physician. At the very beginning, when you're prescribed the medication, how can I dispose of these medications if I have extra? In some pharmacies, they have drop boxes. At some law enforcement locations, they have drop boxes. Sometimes there are mailers available. And I will say that innovation is playing a role here. I talked to one company, and they had a little packet of a material that all you had to do was pour it into the pill bottle. It would gel, and then you could throw that away. So the key issue is this is an important conversation to have. There are many options, so I would talk to your pharmacist and your doctor when you are first getting the prescription.
Thanks, Dr. Harris. Similar question as far as how to get something. Where can people get Naloxone or Narcan? And this person says, in case I ever need it to help someone.
So I'm happy to start. Georgia, like many other states, has taken really important steps to make Narcan available. There is a standing order so that anyone who wants to access it through their local pharmacy is able to get access to this life-saving tool. And I'm also happy to report that even individuals who are uninsured or might want to access it through a local nonprofit can reach out to the Atlanta Harm Reduction Coalition or the Georgia Opioid Prevention Program, and just ask for it, and it's made available to individuals. Our organization has also made it available to first responders. Anywhere we can, we want to encourage people to reach out, get it in their hands, especially when they know loved ones are at risk.
Thank you, Commissioner. Next question. My daughter is addicted and has relapsed twice and has overdosed. We cannot afford inpatient treatment. No one has ever recommended medication-assisted treatment. I'm afraid she will die from an overdose. What can I do?
Let me start with that one and give some general information, because most treatment for opioid use disorder is done on an outpatient basis, doesn't require the expense of a residential stay. And she could either see a medication provider or go to an outpatient program like Dr. Welsh runs at Emory. And I know there's other resources all over Georgia that could provide such medications, but the important piece is that people can access these medications without going to residential treatment and get the support services necessary.
Commissioner, would you like to add to that?
Yes, I'm happy to let folks know some really important resources that are available in Georgia. And they are available through funds from the federal government, provides funds to each state. In Georgia, the Department of Behavioral Health and Developmental Disabilities has put a priority on making medication-assisted treatment available, particularly for people who are uninsured. And so with monies that we've received through the State Opioid Response Grant, we've invested in standing up over 23 medication-assisted treatment sites that are available to individuals who are uninsured or do not have ability to pay, so they can still walk in, access treatment. I also want to let folks in Georgia know that the Georgia Crisis and Access Line is a 24-hour hotline staffed by licensed clinicians where you can call. Tell somebody where you are, what location you're in, and they can direct you actually to the local resources that are available in your community. And we really want to encourage people at that first sign where someone says, I need help, I want help, or you're looking, go ahead and make that call.
Those 23 centers you're talking about, is it a case where people have to be referred by a primary care physician, or can people contact them directly to get help? Because sometimes I feel when there are a lot of steps, people are less likely to do something. Is it a pretty direct shot to be able to get served by those centers?
Absolutely. The idea is you should even be able to walk in and at least have the conversation, right. I'm here, I'm seeking help, or I'm seeking help for my loved one. And if they can't help you right there, they can certainly direct you to how you can make that happen. We want to make it as easy as possible for people to access the treatment that they need.
Excellent.
And if I could add a broader point,
sure.
Because I think people equate treatment with residential or inpatient. And I think we need to make sure that it's about the treatment opportunity that best fits the individual need of the person. There is no one-size-fits-all approach. There are outpatient opportunities. And so I want everyone to broaden their horizon about what a treatment opportunity actually is.
Especially because not everyone can afford to do an inpatient treatment. Knowing that there are other options open up so many avenues for people.
Absolutely.
Our next question is, where do things stand with access to treatment for people? How are we breaking through barriers to expand that access? Who wants to take that one for us?
Well, I will start with a broader approach nationwide because the last set of data we looked at, and it does depend on where you live, but only 2 in 10 patients who wanted access to medication-assisted treatment, which again is evidence-based, had access to that treatment. That is 2 in 10. That is totally unacceptable. Now, we are seeing more and more treatment opportunities available, but we have a long way to go. And I really was very glad to see in Georgia that there are more and more treatment opportunities for those who don't have any insurance. So I think we are improving, but we still have a long ways to go before we make sure that everyone has an equitable opportunity for access to medication-assisted treatment.
What about the COVID impacts that we're seeing, these overdose increases that we've seen in the state of Georgia since March when we shut down? What is our takeaway from that? What do we do with that information other than be very concerned? How do we take that information and move it into action and how we react to it? Anybody have thoughts on that?
I'm happy to start and really raise the concept of the importance of peer support. And when we use that term in the context of opioid recovery and treatment, we're talking about people who have been through their own opioid struggle, are on the other side of it, and then are trained to help individuals. So peers are active in Georgia all around the state, and they have embraced the opportunity to take action during COVID. And they're having recovery meetings, online, virtual recovery meetings. And there's also a warm line in the state of Georgia, where if you just want to say, I'm not in crisis, but I need to talk to somebody, I need help. We also have peers. There's a peer on the other end of the line to listen, to talk you through, not necessarily to do anything, but just to be there to listen. We've also placed peers in emergency department rooms where after an overdose, rather than just necessarily talking to a healthcare or medical professional, they might want to have the next conversation with a person who's been there. Peers are right there at the other end saying, let's talk together about what's going to happen next. So I think grasping that first moment where a person says, this isn't the way I want to live, I want to find help, having a connection of another individual who's been there. We've tried to really make it possible for peers to support other individuals all throughout the state. So there are peer recovery centers in communities all across Georgia. Again, places you can walk in and say, can I talk to someone? I think I need help.
Excellent. Dr. Sepulveda, I'm sorry.
If I could add,
go right
I think
ahead.
the other learning moment that we've had during COVID is the opportunity for telehealth and access through services through telehealth. And my co-panelists may be able to more specifically talk about what's here in Georgia, but I know nationally, at the federal level, there were several regulations and restrictions that were loosened during this time that really incentivize access to treatment at all levels through telehealth. And so I think that's been an important learning moment. Now, we will still need to learn about that because we have to make sure that privacy and confidentiality are valued even through telehealth. And we still have to look at some regulations and barriers and actually payer requirements that limit access. And here in Georgia, we have to think about access to broadband. Because if you live in a rural area or an area where you don't have access to broadband, then telehealth, though it may be available, may not be available to you. But I think that is an important learning moment through COVID.
I think that's very true. You know, we've had the conversation for years about telehealth was coming, and COVID forced everyone to embrace it, right, in an ambitious way. And now that we see it is really becoming a lifeline for people. I know that there's work to be done in that area, but it's encouraging to see. Dr. Harris, Dr. Sepulveda, Dr. Welsh, and Commissioner Fitzgerald, thank you so much for your insight and advice today.